Susan, can I do a quick audio check with you? We're good?
Yes, you sound
All right.
great. How do I
Thanks.
sound? Can you hear
Fantastic.
me?
Yep.
Okay.
Hi, Susan. Can you hear me okay?
Yes, I can hear you fine.
Great. And do we have Member Walsh today?
I believe he is out today, Chair Foster.
Great, then it looks like we have everyone. I'll call to order the Green Mountain Care Board's hearing of March 20th, 2024. We have one substantive agenda item today, which is the fiscal year 2025 hospital budget guidance. We have removed the agenda item for the Copley mid-year request. There was some additional information board members wanted, and they wanted more opportunity to evaluate and consider the request. And so we need a little bit more time on that. I don't think we've rescheduled it yet, but we're planning to do so shortly if we haven't already. With that, I'll turn it over to Executive Director Susan Barrett.
Great. Can you hear me okay, Chair Foster? Okay, great.
Yes.
So first of all, I want to remind the board and the public that this evening we have our primary care advisory group. We will be reviewing. You can't hear me. I'm gonna take my camera off. Is that any better?
That's better.
We will be reviewing the hospital budget guidance with the primary care advisory group and gaining their advice on the FY25 hospital budget guidance. In addition, we have several public comments open. I urge folks to please take a look at our page. There are 5 or 6 listed, but I will tick them off as a reminder. First, the board is accepting public comment on guidance on the assessment of affordability in the review of rates. We ask that folks who are interested in submitting a public comment that they do that by the end of the day on April 9th for board consideration prior to the board's review of this guidance on April 24th. There are materials linked on our public comment website. Also, we, as Chair Foster mentioned, we extended the period to accept public comments for the Copley Hospital's mid-year FY24 budget request. And so please submit any comments by the end of the day on March 25th. We would like those in consideration of this issue which will be before the board on March 27th. We are also accepting public comment on the draft FY25 hospital budget guidance, which we will hear more about today. And then the last 2 ongoing public comments or periods are on the community engagement for hospital sustainability. Please share any public comments on that process with us. And last but not least is any public comments regarding a next all-payer model, at this point, the AHEAD model. Any comments we receive, we share with AHS and the governor's office as they are leading the negotiations on that model. And with that, I will turn it back to you, Mr. Chair.
Thank you. We have our meeting minutes from March 13th, 2024, and I will move for approval of those meeting minutes. Is there a second?
Second.
And all in favor, say aye.
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 Aye. And the minutes are approved with 4 yay votes and Member Walsh absent. With that, I'll turn it to our hospital finance team for presentation of the 2025 hospital budget guidance. And that will be led by Elena Barabee, our Director of Health Systems Finances, and Matt Sutter, our Health Systems Finance Principal Analyst, and our staff attorney, Russ McCracken.
Great, thank you. All right, I will share my screen. Let me know when you can see it.
That's up.
Great. All right. So today we'll review the modeling that we discussed last time. I'll note a couple of updates to the guidance. As you know, it's posted publicly in its full form, so I won't be reading it to you here today, but I'll be kind of going over the high level structure and some of the updates we've made. I'll talk about the uniform reporting manual briefly, the hospital budget review measures inventory, and discuss timeline and next steps. So there are these 3 materials that I kind of mentioned in the previous slide, but I want to kind of remind folks what they are and the purpose and how they work together. So the FY25 guidance document specifies how budgets will be evaluated and criteria for whether they will be adjusted, and kind of notes some of the kind of content areas that we may be looking at when we evaluate and analyze those budgets. The uniform reporting manual is a manual for standard definitions for financial and eventually non-financial reporting requirements. We'll talk about this in more detail, but I think there's a lot of future work that we could do here to update this manual. We kind of did what we could this year with limited staff, but it's largely similar to last year's reporting manual. Hospital budget review measures inventory. This is a new document this year that kind of codifies measures that we've used historically, or some version of those measures or new measures that we've discussed recently, and just creates transparency into how those measures are calculated, the data sources, the years that we would use, and we expect to work towards visualizing many of these measures. I'm not sure how much we can get done this year, but this is kind of a long-term effort and kind of step 1. In creating these materials and the budget guidance and benchmarks this year, we have been sourcing quite a bit of input and sharing different versions and asking for advice and guidance. We started this immediately following last year's budget process. I was kind of onboarding at the time, caught the tail end of the hospital budget process, but met with folks afterwards to hear how they thought things went and what could be improved. We also met with the CFO group in November to receive some preliminary feedback on how last year's process went and what they had hoped for this year. We had a series of meetings since then with hospital CFO subgroup, HCA, members from BOZ, and a critical access hospital that looked at kind of various versions of the guidance and the metrics list. And as you know, we've had a series of board meetings to discuss kind of the approach in general. And last time we met, we kind of went through in detail how we would structure the guidance. And it's been posted now for, I believe, a week in its full form. And we're still open to public comment, so there's still time to influence the process. Just a reminder that, these materials together kind of balance what we hope to be a predictable but adaptable process. This is not a formula that, we press a button and we know what the perfect budget is. This is a really messy world and requires a lot of triangulating and trying to ask questions and understand broader trends and what's nuanced at the local level. So this guidance really seeks to optimize these things and is certainly a movement in a direction and can evolve over time. So this is a slide you should be familiar with. It's the same that we discussed last time. So really the section 1 benchmarks in the guidance will kind of be the first step. So if a hospital's budget meets those 3 benchmarks, we wouldn't expect to adjust the budget unless there's something strange with the assumptions. The budget doesn't tie out or some major assumptions related to, subsequent years are ignored or, look strange, we might have more questions. But otherwise, we would expect to approve that budget. We will still conduct a full review of all hospital budgets, even if a hospital meets all of the benchmarks, just so we can learn. But perhaps we as it discussed in the guidance, there would be options for exemption to for a public hearing if hospitals do meet all of those benchmarks. If the budget does not meet the benchmark, we will, again, start with the budget assumptions and try to understand if those are reasonable. And then we'll kind of look into the section 2 comparative analytics. So really thinking about, why, asking questions about what's different about this community or this hospital, or what, why would you need a higher rate or lower NPR or higher NPR? So I think that's how we're thinking about that. So to Rich, last time we proposed, keeping the NPR benchmark and tying this to the all-payer model growth target of 3.5 to 4.3%. And then hospitals would be expected to justify the benchmark, justify if they exceeded that benchmark in their budget. We talked about picking a either 3.5 or 4.3% to have a clear boundary. And so I wanted to share some trends with you. This is NPR over time, so growth from fiscal year 17. So the blue bar lines are actual NPR. The purple line is the FY24 budgeted NPR that was approved. And the green growth line that you see there, the dotted line, is what NPR would have been with a 4.3% growth rate starting in fiscal year 17. The orange line is what the growth rate would have been at 3.5% growth. And, we certainly know we had some challenging years in between. So these are just reference points. It's not saying that's where we should be necessarily, but it's to give some broader context. And then the blue line is is a inflationary index that's associated with growth in healthcare expenditures or consumption of healthcare expenditures. This is a different, you'll see PCE index. This is a different index than what we talk about later. This is really about volume and price. The index we talk about later is really only about price. So this is representing aggregate volume. So the compounded NPR growth rate since 2017 has been just about 6%, just over 6%. If we stayed at 4.3%, this would bring us to a 3.43 billion in 2025. If we stayed at the 3.5, so that orange line, we would be at 3.2 billion. And so the table below kind of shows, what our benchmark would be if we started with 24 budget and added 3.5 to 4.3, which is what we've proposed in guidance. We're not saying we should go back to the 2017 rate, but, we need to pick a threshold. So, I think we've been growing a lot more than I think we all had expected over quite some period of time.
Hey, Ms. Barabee, can I interrupt with a question?
Sure.
Can you go? Okay, so the 25 line that you have here, that comes out to like 3.7 something billion dollars.
Right. Mm-hmm.
And so if we had stayed at the 4.3% all-payer model target, we're about 300 million above that at 4.3 and about 500 million above that at 3.5. Is that the point here?
Yes, that is the point of that chart. Yes.
And this 25 fiscal year 25 number you have, that's at a 3.5% NPR benchmark.
Yes, relative to that purple line, the fiscal year 24 approved budget. So that's how many additional dollars we would be adding to the system if we hit that, right? And this all needs to be taken in context, with what we've grown, the budget, and then there's, there will be actuals on top of that. So, but we're building to what's budgeted in 24.
Thank you.
So this, trying to understand why we're growing. I think we've spent a lot of time thinking about this, but I wanted to start with volume. We hope that by increasing NPR, we'd be expanding access. The chart on the left takes all of the New England states from the data underlying the NASHP cost tool that looks at adjusted discharges by state. So this is a, a crude measure. It's not perfect, but what we're showing here is it's other than with the decrease in 2020, it's been relatively flat, where there's not a huge growth in the volume of services being delivered in our state, and that's consistent. So the chart on the right is exaggerated in visualization, but just making the point that it's been pretty flat over time with this decrease in 2020, but now in 2021, 22, we're catching back up to where we were before. If you look at hospital admissions per 1,000, so at a population level, we know that hospital admissions have been declining over time, and this is a broader trend. And we know, some of this is because we're seeing more outpatient, which you saw on the other slide is relatively included there, relatively flat. When we look at what's reported by hospitals in the discharge data set, we see similar trend. So it's, that dip in 20 and then it catches back up in 2021. We don't have these data for 22 and 23, so it would be great to kind of see where we are now. Maybe something's different, but this is kind of the latest available data we had as we were developing these slides. So if we look at, so we don't think it's volume that's driving this growth, but if you look at expenses, we have to see with more recent data, but if you look at expenses, there's certainly a correlation between the NPR and expense growth over time. So we've added here this top green line, which is actual operating expense, with it trended to 24 based on budget. So you can see how that has been increasing at a similar rate. So if we look at operating expense growth, again, this is using the NASHP cost tool data as aggregated to a state level. So it's total statewide hospital operating expense. So it's a crude measure, but you can the yellow line across the top is Vermont. So we're, much smaller piece, but we are kind of growing in line with other New England states. So if you look at the right, this is year over year growth in aggregate. We're, kind of in the middle there compared to other states. If you look at operating growth per adjusted discharge, you can see that Maine and Vermont are kind of at the top end of New England states, but in terms of growth, we're rather consistent with our peers across New England. When we look at charge growth over time, you can see that prior to 2020, it was kind of more moderate. 2020 happened, and then there was this big catch up. We had inflation and a number of other challenges, and so operating margin, which is that green line, took a hit, and charges kind of spiked consequently. And so we can see the real impact of increasing operating expenses on charges and price. So given kind of, this substantial growth, staff are recommending that we stick to the 3.5% to kind of try to level things out over time. And, again, we kept the language, hospitals exceeding this benchmark will be required to justify why they would need more than 3.5%. So this is not saying that 3.5%, that's it. Hospitals can certainly come in and say we need more than that, and here is why. But the burden will be on them to prove that case. We also discussed last time a benchmark for, containing prices of healthcare services. So if we really, step one, we say we really need more volume, but we're going to hold our prices down, or, improve or lower our prices. That would be amazing. What is an appropriate cap on what consumers should be paying for hospital services? And so we came to you last time and asked, what index should we tie this growth rate to? What level of analysis should we peg this inflationary metric to? And then, should we by payer, by care setting? And we had this list of inflationary metrics that are quite common across a variety of sectors and in healthcare. So the first one is really about GDP and price deflator. The second one is CPI. The third one, which we're recommending, and many of these are quite similar from the consumer perspective, but others are more about industry and costs and supply costs. So because this is about, we want to have a consumer lens and make sure that we're thinking both about affordability and kind of health system growth at the same time. We adopted one of the more consumer focused metrics. So the fourth one is a personal healthcare deflator projected by the NHE. The fifth one is a PPI, or the Producer Price Index, employment cost indices, and Medicare market basket. So we kind of explored all of these, thought about how they would correlate with what consumers can expect or can afford, and how variable these are over time. And you can see in the rightmost column here are the kind of latest metrics that we would be thinking about applying to an FY25 process. Some of these are lagged, some of these are projections, so you have to keep that in mind. But what we're recommending is the PCE price index plus 1%. We think adding, this is one of the more conservative measures, but adding 1% will kind of bring it in line with some of these other supply side inflators, but would also give some room to grow. So we know that this indicator catches up over time, but we know because it's a lagged indicator, having more wiggle room, especially as we're trying this out as a threshold, would be appropriate. Then we wanted to kind of take some of I didn't do this for each of the measures, but, compared to Medicare market basket, the NHE healthcare deflator, personal healthcare deflator, and the CPIU. And what you can see is that this is actually a more generous threshold. So I took PCE price index plus 1% and subtracted the rates of growth from, these other indicators. And what you can see is it's generally above, except for CPIU in 21 and 22. And that is, so they're, they generally hold over time, but CPI kind of bounces around a little bit more based on how it's calculated. So we've applied this PCE price index plus 1% to charge growth over time. This is kind of a year-over-year look. The blue bars is PCE price growth plus 1%. The orange bars are what we ended up approving in the hospital budget process. And then if you look at this from a 3-year kind of cumulative average lens, so this is kind of smoothing, you can kind of see that it holds over time, but that we have approved, a chunk higher than where this price growth indicator has been historically. So staff are recommending that as for the Section 1 benchmark that, we set this amount to the price inflationary metric plus 1% as of the January 2024 release. That's the most recent one available, which amounts to the 3.4% for FY25 over FY24. So this cap would be a cap on commercial rate increases for each hospital above their currently approved levels, which also would apply as a cap on that which hospitals may receive in price from each individual commercial payer. So we really want this to be net of utilization. It's really focused on price increases. And then, the GMCB approved rate increases will be capped. So there's still, negotiation that would happen between hospitals and insurers beneath that. And then similar to the first benchmark, hospitals proposing budgets that exceed this growth rate will be required to justify the request and report on productivity by department. And then we, in order to kind of round out some of the, understand some of the assumptions related to rate increases across payers, this is kind of in building on the previous ones. This isn't setting the benchmark, but reporting. Just wanted to note that we would expect reporting by payer for each major payer, but also by the core service line. So inpatient, outpatient, and professional services. The last benchmark included in Section 1 is less of a benchmark, but more kind of like a threshold for operating margin of greater than 0%. So that's just saying, we expect that a hospital, in order, if it's going to be efficient, would have to manage its expenses, and we would expect that a highly efficient hospital would be able to both bring in sufficient revenue, but also be able to manage its expenses. So again, this is just reiterating, it's a similar slide to last time, but just that the Section 1 benchmarks are what kind of dictates whether we do a full review with potential adjustment or a full review, and perhaps there might be some questions or reporting if something looks funny, but this is what will dictate whether we adjust a budget. Guidance structure, we tried to consolidate a little bit, so we don't have the monitoring section. We just kind of included it all within the contextual information section, and then created another section to really detail hospital reporting requirements. So a lot of the previous sections discussed kind of general measures and data sources, but some of those are public data sources, and we wanted to make it really clear like what the hospital will be required to report. So that's now in Section 6. But otherwise, this is largely the same. I'll breeze through some of these slides, which you've seen already, which is really the purpose of the comparative analytics section, or Section 2. So it's really to use, series of data and trends to try to understand, why a hospital might not meet the benchmark set in Section 1. So this is really to facilitate a conversation. We don't think there are, 2 measures or 3 measures or a handful of measures that will adequately describe a local context. So that's why we didn't set a specific performance benchmark. So it's really about understanding across a variety of financial measures and access measures and community level measures. So we think it's important to have a holistic view of what hospitals are dealing with on the ground. This is a snapshot from last year's budget tool, the types of measures that are included, and, feel free to, if you haven't already, I hope that you've looked through that measure set. They have kind of categories and tags, and you can filter them, but they're, many of them are to do with revenue trends or operating efficiency, financial health, and they're labeled as Section 2 in that tool. Section 3 will details kind of what we're looking for in terms of budget assumption. So being clear about, what reimbursement changes are reflected in this budget or not, payer mix changes, service mix changes, patient acuity, utilization, anticipated future capital investments, or other material changes and assumptions that staff should be aware of. The narrative, we just created, built on prior year, but tried to kind of organize them around background budget questions and then hospital and health system improvement. This is just a snapshot from the reporting section that we kind of pulled out. So this filing checklist should look familiar. It's very similar to last year, but we are going through and detailing more detail for each of these individual items about what level of detail are required to be reported. As I mentioned before, the Uniform Reporting Manual. So now we're to this second companion document. We made a couple of updates this year, but it's largely similar to last year. So we defined bad debt and free care in accordance with the IRS definition. We clarified some of the language around clinical and non-clinical FTEs. And then I think we already started reporting in this way last year, but we codified kind of pulling out and separating the Medicare Advantage as a like in the broader commercial segment, and then defining major commercial payer for some of the previously discussed reporting in terms of Blue Cross Blue Shield, MVP, United Healthcare, and Cigna, and any other payer that makes up more than 10% of a hospital's commercial revenue. We think there's future opportunity to improve apples to apples reporting between hospitals. Certainly standardizing definitions in the Uniform Reporting Manual would be a great starting place. So hopefully we can find some capacity to do that in the near future. But I don't think it would solve some of the fundamental challenges and accounting differences. So, if we ever really truly want apples to apples, some of the ideas that have been floated, a single statewide auditor, or hospitals could adopt a uniform chart of accounts. That would certainly be a major lift, but those are, just some food for thought. I did want to spend a couple minutes on the hospital budget review measure inventory. Again, it is also posted for public comment, so it's up there. This is, There are many measures included in this list we've used previously, and many of them are our standard kind of financial metrics. The table to the right shows you how many measures kind of fall into each of these categories. So section 1 has the, the 3 targets and that we just discussed. Section 2 has, a variety of measures that look at financial health, operating efficiency, revenue trends, and some other related measures. I believe the other is bad debt and free care. Section 4 has, so those are those contextual measures, detail measures on access and other community level data. Many of these are from publicly sourced or the Department of Health, other standard sources, and quality. So it looks like there are a lot of measures, but many of these, we've used every year until now. And, some of these measures can maybe more or less relevant for certain hospitals. So, it's really hard to tell, if we were to narrow this down, who would be benefiting or losing as a result of that. And then I wanted to turn it over to Russ for a moment on related policies.
Great, thanks, Elena. So 2 items I wanted to talk about here. The first is there's a amendments and adjustments policy that is a part of the guidance. What we have a draft posted. It's substantively the same as it was last year. There are a couple of changes, which I will highlight, but I don't think they're very material. One is there's a confidentiality section in that policy, and instead of setting out a separate process, I changed it to just refer back to the main guidance so that we're being kind of consistent. And the second, in the section about amendments, I changed some language to better track the statute. There was a reference in there to unexpected circumstances, but I changed that to unforeseen circumstances to follow the language that's in the statute governing any requests from hospitals for a budget amendment. So that is posted for comment, but again, it's materially the same as it was last year. The second thing I wanted to bring up for the board is that there is a standing policy on hospital budget enforcement. This is not a part of the guidance. It was pulled out of the guidance a couple of years ago and made a separate standing policy that was adopted in March of 2021. That policy largely tracks the enforcement provisions in the board's rules in section 3.401. The policy is really around the board's review of NPR variations between hospital actual and budget. And the kind of the upshot of it is the section of the policy that says that the board may review hospitals whose year-end NPR FPP exceed the NPR FPP requirement by 1% above or below their approved NPR FPP. That review will not necessarily lead to action by the board. So kind of wanted to bring this back for the board to think about. It was adopted sort of at the tail end of the COVID-19 pandemic. And so it may be appropriate for the board to take a look at this again and see if it still makes sense to have this kind of 1% NPR variance as a metric for when the board would more closely review a hospital's NPR, actual NPR. I did just also want to note that the policy as it stands is explicit that it doesn't limit the board's authority to review aspects of a hospital's budget other than NPR performance, and it doesn't review the board's authority to review a hospital's budget performance at any time as set out in the rule. So if the board doesn't take any action, this policy will continue to be in effect. If the board would like to review or make some changes to it, we can certainly do that, and doing it in conjunction with the guidance might make sense. So I'll turn it back to you, Elena.
Great, thank you. All right, and this is actually the last slide, so I just wanted to remind folks of where we were in the process. So we posted the draft in March 13th. Public comment is open through March 25th. And then I think we don't expect a vote today. Would love to hear your comments and feedback and coming back next week with a hopefully final draft. We have to issue the guidance before the 31st. So really the end of next week is our deadline. But I will turn it back to you, Chair Foster.
Thank you. This is really impressive work. So thank you all very, very much. I know you've been working really tirelessly on this. I'll turn it to the other board members for questions or comments that they may have.
I can jump in first. So yeah, first of all, big thanks to Elena and Matt and Russ and Flora. This has been a big heavy lift over the last 6 months, culminated in the last crescendo in the last few weeks. So thank you for the hard work and for the, I think, needed innovations. I really appreciate it. I really actually have a few specific questions on a few slides that I wanted to start with, just so that I better understand what we're looking at. So the first one is on slide 10. If it's possible to pull those back up, that'd be great. So just so I understand, on the left, in the statewide adjusted discharges, is that only inpatient discharges, or does that metric include both inpatient, outpatient?
It's inpatient and estimate of outpatient. So
It's inpatient, which allows us to estimate outpatients. That's what you're saying?
Yeah.
Okay, but we don't. Okay.
it's not.
And
Yeah,
then-
it's not exact. It's an accrued measure. Yeah.
Okay. And then on slide 13, where we show this really substantial rise in the operating expenses starting in FY22. I would think, if you would comment on, I would think with this high operating expense above the actual revenue that we would have more hospitals with negative margins. Could you comment on why we're not seeing more hospitals with negative margins? We have operating expenses that are far outpacing their revenue.
I think we have quite a few hospitals that have negative margins. So I can circle back, but I think it's more than half now. They're, may not be the big one, but many of our smaller ones are really struggling.
Or I guess the magnitude of negative margin. I mean, this line is, I mean, just estimating proportions. In FY23, the operating expenses look, what, 20% above the NPR?
Yeah, we can dig into that for you. I don't have that at my fingertips, but I'm happy to provide more detail based on our actuals. Mm-hmm.
And then slide 21. I was curious if you don't have, but if you could provide, that'd be great. Just the aggregate growth numbers, the compounded growth of all of these. I guess the compounded growth would be the most helpful.
We almost stuck that in at the last minute, but I'm happy to get that to you. It does certainly smooth things out. Yep. Happy to do that. I can't hear you, Chair Merman, Member Merman, if you're I still can't, I don't know, is it just me? Can anyone else hear? No, okay.
How's that?
Yes, I
We're
can hear
back.
you.
We're back. All right. Sorry, I had weird like audio glitch on this side, Bluetooth glitch. All right. Sorry. So on, and then two slides down on 23 and 24. Really, I'm trying to understand these, and it's really 24. So if we were to use this PCI price index +1, and we average this over 3 years, it's historical up until 24 what the board has done. And then in 25, we're estimating if the board was to apply the PCE index +1%, and we held to that the 3-year system rate growth would then be just about 7%. Am I interpreting this information?
No,
right?
we're not holding anything. So we're just showing the PCE growth, and this is where our system actually ended up. So this is comparing where we actually ended up to what the inflationary growth was over that period of time.
Right, until 24.
Yeah, let me check those. Yeah, until 24. I have to check the year label there. Yeah.
And then I think, is this an estimate in 25 of where the system would be if we had the, because I think if you look in
Matt's on here. Sorry, I'm going to ask Matt.
Right.
Yeah, you're correct, Dave. Or Dr. Moran. Yeah, the 25 figures on this slide with the 3-year CAGR. That's for the 25. It's assuming 3.4% for all the hospitals.
Thank you, Matt.
Okay, so assuming 3.4% for all the hospitals, a system growth of 3.4%, that we're seeing the 3-year average growth being about 7% if we use the 3.4% growth rate. Is that right, Matt?
Yeah.
Okay.
The compound average, yeah.
But I think that's all I have for now. I appreciate it. I think I'll probably have some more comments in a little bit. I want to hear what other people in public comment. Thanks.
Thanks.
I don't really have comments at this time. I so appreciate all the work that the hospital finance team has done. The data is really enlightening in terms of the trends and the comparative analysis that was put forth. And at this point, I'm more interested in hearing, what other board members have to say. I'm interested in public comment. And I think we have a week to think about it, so I want to digest some of these slides a bit. But I appreciate all the hard work.
I have a couple of questions. Can you go back to the slide that has I think it's 10, the NPR operating expense? Nope, sorry. Yeah. There you go. Sorry about that. 13, I didn't write it down. So just following up from Dave's question related to the negative margins. I'm just trying to think through with the operating expenses where they are and the NPR. As many of the slides pointed out, it's the operating expenses over the last few years post-COVID that have been driving both NPR and the charge increases. So in thinking about how to move back towards a more sustainable growth rate, it would be helpful for me to understand how do you start to reverse that trend on the operating expenses. So, because to me, like understanding that piece, if in terms of picking 3.5 or 4.3, which is more realistic and reasonable given where actual expenses are today, understanding that there are things you can do to moderate expenses. But what is a reasonable trajectory? Like, if I don't know if what I'm saying makes sense, Elena, but just trying to think about, like, on the ground, what's realistic and reasonable in terms of moderating the trend, understanding that half the hospitals are in the red.
Right. I mean, I think that's why this is a benchmark that, hospitals can justify why they need more than that, right? So I think this is really about, it's an aspiration. If we don't set an aspiration, I don't think we'll be able to reach that more reasonable growth rate. So I think we really need hospitals to help us think about, I mean, they're the experts in their operating, how they operate, right? So I can't tell them how to do it. I mean, that's why we're doing this Act 167 work. But I'm hoping that they can really come to the table and have some informed conversations about how we can all work together to do this.
Thanks. I didn't have any other questions about slides. I did have a couple of comments on the guidance document, which I will not ask you to pull up because it's too long. So I'll just throw a few things out there. In section D of the guidance, it asks for lots of really interesting information related to, and this is my interpretation, so feel free to say this is not what you were shooting for, but when I looked at it, it seemed like it was really trying to get at capacity for change, existing improvement infrastructure, existing efforts with the community. I think that's all good stuff. I am not sure that it's that amenable in a narrative format. My concern is that either you get a 20-page answer or non-answers. And so I'm just questioning whether there might be another format for getting that information and having a conversation about those issues other than through the budget narrative. There are...
You went on mute, but
sorry about that.
Okay. Yeah, you're talking about another format.
I don't know how that happened since my hands were nowhere near the keyboard, but creepy. Anyway, so yeah, so I was wondering if there's another format we might consider to have more of a conversation about those sorts of issues. Not because they're not important or interesting, but because it seems like the narrative format just may not be the best way to collect the information in a meaningful way. There are several questions in that section that are directly applicable to the budget. But a lot of the other ones I would categorize as interesting, but not necessarily directly helpful to me making the two key decision points. So that's a suggestion. Just because I think that I want the information, I just am not. I want it in a way that is most meaningful for everyone. Let's see. I had some specific questions around a couple of questions in the budget section. And I've raised this 2 years in a row about the facility fees question. I still don't really understand why we're collecting this information and how it helps us in our decisions. Facility fees are driven by Medicare payment policy. So I was curious if this is meant to be trying to get at commercial payers that may have adopted Medicare payment policy. So that's just a question. And on the penalties to CMS question, are we truly talking penalties? Was it meant to capture, for example, quality adjustments? Or I just wanted to make sure that we really were asking about penalties versus other sorts of adjustments that CMS might make. And wanting to understand a little more about that question.
Sure. Yeah. Thank you.
I think those were the bigger questions I had. Thank you.
Thanks. Yeah, and I'll take those back and follow up next. Thank you, Robin.
If I can just hop in on that last question that Robin had, I do think it's important for us to understand if a hospital has received a penalty because of a quality, readmissions rates that are too high from Medicare. I do think that should factor in as something we should understand going forward. If it's happened frequently, if it's been, readjusted back up, I mean, what is the process there? But I do think it's an important metric for us to follow.
Thanks, Jess. I guess I wasn't seeing that as a penalty, more as a quality adjustment. So penalty to me means you violated something and there's a legal consequence. So maybe it was just me being overly technical and reading that term. So that's why I was asking the question.
Right. No, it's a great question. And maybe the term should, we can work on the question better, but there's a quality adjustment.
I have no questions.
Chair Foster, I believe you're breaking up.
Really close to the guidance for places that are.
I can't really hear you. I'm wondering.
How's that? Is that better?
That's a little better.
I don't need to comment. We'll go to the health.
We in the public, we have no idea what Chair Foster just said.
I think he said, I don't need to comment. We'll go to the healthcare advocate.
Okay. That's what I thought I heard.
Thanks, Mike.
Good afternoon. Sam Parish for the Healthcare Advocate's Office. I'll be brief. I just wanted to thank Elena, Matt, Russ, and Flora for some really great work. I will say, in my time with the HCA, this is the most evidence-informed and rigorous guidance that I have seen. And I know they'd probably be quick to point out that this is a byproduct of continuous improvement over the years. We'll probably submit a brief technical comment about an affordability metric that's a little bit different from the one that's proposed to be benchmarked to the commercial cap. But at a high level, the main comment I want to make is about the process itself. The HCA thinks of defining a successful process as one that's participatory and not performative. And one success is not based on whether or not we get everything that we want, is whether or not we were heard and there were multiple clear opportunities for feedback in a transparent way. And we certainly feel that way. So we want to thank the team for leading the process that is conducted that way, and look forward to providing comment on it moving forward. So thank you.
Thank you very much. I'll turn off my video in hopes that it helps with my audio. Is that okay? I'll turn to the public for any comment via the raise your hand function. Mr. Davis, please go ahead. Ham Davis.
Hey, can you hear me now? That's my fault. Can you hear me now?
You can now. Yes, go ahead.
Sorry about that.
Yes, sir, we can.
Okay, I have 4 comments. I'll go as quickly as I can. The first is that consistently since this board has been operating in its current configuration, which started in 2017, I think it's a huge mistake to consider this simply as one system of 14 hospitals. It has nothing like that at all in the real world. There's 2 systems, not one, and it may be 2.5 if you consider the New York side of UVM the UVM Health Network. But the hospitals, the UVM network has a completely different business model from the community 11 community hospitals, and if you and they operate completely differently, and treating them the same is just going to get you, in my opinion, nowhere. Secondly, one of the huge issues that is happening now and is confusing the legislature, the administrative, the Scott administration, the whole thing. One of the things when you look at the cost, especially federal, looking at federal benchmarks, the critical question is whether what you're looking at is age adjusted or not. If you look at something like the Kaiser Family Foundation numbers on which state is most expensive, Vermont is one of the 3 or 4 most expensive. Okay. Now, if you just take that, if that's just raw data, okay, then that's one thing. But it isn't. The fact of the matter is that Vermont is one of the 3 or 4 oldest states in the union. The average age in Vermont is roughly in the mid-40s. Now that whether you use the average or whether you use the median, then they're different, as we all know. But there's not very much difference between them. Most states are average ages in the 30s, and so by not age adjusting, okay, then then you're just not taking into account what the reality is. Vermont is hugely old. It's even old. It's old not just all over the state. It's old in Chittenden County. I know something about it. I'm one of them. And so in any event, by not age adjusting, okay, then I don't believe a single thing that you have to say about what's going on in the healthcare system. It has to be age adjusted. Number 3. 2 years ago, Mr. Chairman, you told me that you told me an answer, which I appreciated, that the huge volume of data that came in from something like 400 pages that came in from half a dozen national consultants into the Green Mountain Care Board on October 27th of 21, and you said specifically you weren't afraid of that. Well, I have to say that I think you are afraid of it, because I haven't heard a word about it. What that data is talking about is the quality that's going on in here. There's 3 different quality measures that all cohere to say that the UVM Health Network quality is way higher than the rest of the state, all of it. And so the fact of the matter is you're not touching that. If you can't use that data, okay, then you're not going to get anywhere trying to regulate this system. The fact of the matter is you're not moving the needle at all. The actual way medicine is getting delivered every day, okay, is not changing at all, according to what your board is doing. If you think it is, you're just kidding yourself. Fourth, I'm almost done. Fourth, I'm writing a book about this, okay, and what I'm doing is I'm making all kinds of judgments. I can be wrong. I don't know, whatever. People can disagree with me. In conventional journalism, which doesn't exist anymore really anywhere in the United States, and certainly not in Vermont, but then it's a journalistic principle, okay, that you give the people you're talking about a chance to reply to what you say. They can object. They can argue with you. They can tell you you're wrong about something. And if you're a competent journalist, then what you'll do is you will listen and take all of that into account. I will do that, okay? But it's very hard to get through to people now. Very hard. I get calls when I make calls into your system. I get called back 1 out of every 10 times, and mostly that is Kristen, who's doing a great job, by the way. In any event, if you, I will send when I have a specific question for a member of the board or a member of the staff, I will send it through Kristen. I have already done that once for one member, okay? But I will do it for all the members, and it's your choice. It's nothing personal. I have no problem. If somebody doesn't want to talk to me, that is fine. I know a lot about that. I covered the whole Nixon administration. If you think that journalism is a problem now, you should have been in the Nixon administration. Anyway, thank you, Mr. Chairman.
Thank you very much for your comments and thoughts. Ms. Gutwin?
Hi, I just wanted to make a comment about the statistics, which, by the way, I thought were well presented, and most of it I could understand. So that says a lot in your presentation. With the statistics looking at both inpatient and outpatient of a hospital, and separate from all the rest of the outpatient services of a community, it's like looking at the cost of healthcare in a vacuum. So if, for instance, if services are shifting from inpatient to outpatient, but your metrics only look at the outpatient of the hospital, and you're looking at expenses that aren't broken out between inpatient and outpatient, you're not able to understand cost savings that that definitely exist in outpatient services that are non-hospital based. So I think it's a good sign that actually inpatient care is decreasing, because for the healthcare system to save costs, if we can shift it to outpatient, and in that outpatient shift, there is more affordable healthcare, then we're looking at an overall decrease in cost to Vermonters. So I don't see a way for the Green Mountain Care Board to do it just looking at the reports that I see, because it doesn't include what is outpatient services, non-hospital based. And I think that is a good thing to look at, especially now, because outpatient services, businesses are still at high risk of going out of business. I know that we have lost a spine business. So now the only choice patients have is a hospital-based spine service. And the other thing too, for me, I have a knee injury, and I want to have surgery at UVM. And to schedule an appointment, you have to see the PA first. That's understandable. You can't see the surgeon. Their dates are 3 months out for the first visit. And then I called Evergreen Family Practice, and they could see me within 3 days, which I did. And then same with MRI. That wait list is far longer than what I have, which was within 24 hours. So it's critically important for the Green Mountain Care Board, if you can't get reports on the outpatient services, and every outpatient service the hospital provides can be provided by another business. If we don't consider that, then we look at the trajectories. We see the expenses of the hospital growing far, far higher than what we have in outpatient services of other businesses. So in other words, as I have said before, hospitals used to do hospital work. They used to take care of the sick and injured that couldn't be handled in doctor offices within the community. When the hospitals have encroached upon outpatient services, then what we have is a grab of services that aren't more expensive to deliver, but more expensive. And I even wonder, I mean, my theory is, if a hospital has now both outpatient and inpatient, if inpatient is struggling, maybe their outpatient prices, the cost of now basically 4 times what you would have to pay to a non-hospital base, is to shift money from outpatient to inpatient. And I really think that hospitals getting back to focusing on their core duties and helping them to be sustainable, like we can sustain hospitals better if we basically allow other providers to do outpatient care, where possible, so that we can save money to raise the price of hospital services and inpatient care. But what we cannot do is we cannot not think about these businesses in the outpatient realm that are non-hospital based, because we had testimony that Blue Cross and Blue Shield says we can't raise rates to anyone when the hospital basically has the majority share of cost increases. So that's my comment. Thanks.
Thank you very much. Mr. Del Trecco.
Thanks, Chair Foster, and thanks, board members and Elena and your team. Ham and Susan, tough acts to follow, so I appreciate their comments as well. You know, I don't think we are in a pointing the finger conversation. I think Vermont has an economic crisis on our hands. Vermonters can't afford healthcare. Vermonters can't afford groceries. Vermonters can't afford gas. Vermonters can't afford their phone bills. It is an across the board problem. This is the first time I've seen this deck in presentation like most. I think the perception of Sam is not shared by me. I think we need more context. I think we need more work. And if we look at the timeline that was laid out, I think some of it is insufficient. This is the first meeting we're having on the 20th, and we're going to approve guidance in 10 days from now. So I think we need more clarity and more predictability in this space. When I think about some of the slides that I've seen, there's great data and information. There's great data. There's not a whole lot of information. I'd like to ask why that operating expense growth is growing. What are the elements driving that? It was stated that an organization that can manage operating expenses is highly efficient, and we are the experts. However, when we do talk about those drivers and concerns, it's met with those aren't realistic growth rates, and we can't continue to grow this way. Again, I think we have an economic issue. I don't think it is solely a one organization or one industry issue. When I hear the comments around Blue Cross Blue Shield not being able to afford or pay other physicians, that's highly concerning to me. We need to look at the holistic picture and what is happening, and it just can't be one person gets paid versus the other. This is a race to the bottom. So I'd like to ask for a few things. One, we need to recognize what drives expense is when a patient shows up at our hospital. If a patient doesn't show up, that's the cheapest form of healthcare. And especially if there's care is delivered outside and they're not avoiding care. Just make that comment. So we are looking at how do we care for our community. We want vibrant communities around the state of Vermont in every rural corner, and we're focused on caring for our patients. So I think we need to deconstruct some of the information around hospital expenses and growth, decouple that from what might be considered highly efficient. And I know, Chair, I appreciate you being at our board meeting yesterday. There are 96 measures. There's no way on earth any organization can measure 96 measures, understand what they are. And I actually feel for the Green Mountain Care Board staff. How are you going to analyze 96 measures and be effective and efficient and productive at that? I think it dilutes the point of what we're trying to do in a data-driven way. Furthermore, in that space of those metrics, I think there's challenges with some of the benchmarks. I think there's challenges with not knowing the inputs, the numerators and denominators, and I would like to avoid at any cost what we ran into last year during the budget presentations in July, August, and decision making, where there was a lot of confusion around those measures. So I would ask, one, that when we approve guidance, that those measures and metrics are clear. I would ask for a reduced set of measures and metrics and benchmarks. And if that can't be accomplished within the March 31st deadline, I think there needs to be some reasonable no later than date set. We know that July of last year didn't work for a timeline, and I would ask respectfully, could we shoot for April 30th? As we move into past April 30th, our organizations will start to be looking and managing and modeling ahead model details, and I'm worried about the capacity of our organization. So I know I was long-winded, and I don't usually filibuster like that, but there's a lot here, and it's important. I appreciate the work and collaboration, and I just think we have more to do here, and we don't have much time to do it. So thank you, and I appreciate the time.
Mr. Del Trecco, I'll have a follow-up question. I'm sorry I can't be on video with my reception here. Do you have a set of the 96 measures that you would like to see removed or that the hospitals think are not productive or relevant?
I thank you for that. I know that there's been a small work group looking at some of those, and I think we can work with Elena and her team on that, because I do think there's many measures that are very important, and there's some I'm not so sure about. But the answer is yes. I'm happy to work with you on that.
Okay, yeah, I would definitely be interested in which ones you think we should remove, and definitely take that under consideration. So send that in for sure. I think it'd be helpful. And then just for, thank you. And then for context, the benchmark, the only two real benchmarks are the rate and the NPR. And the way I look at the measures is if the hospital is going to be above those, these measures are something they can point to and rely on to justify that request. So, for example, if they're low cost, low prices, low expense growth, whatever it is, the justification for board members, I think, is strengthened, or at least for me it is. So they're really things to kind of help hospitals know what could be relevant to changing board members' minds to support a higher rate increase. That's how I think of them.
Yeah, I appreciate that, and thank you. And again, I think for us, it's about how do we care for our communities in the most effective way. We're looking at healthcare in a very holistic way, housing, what our local towns and city streets look like, workplace violence, patient safety, and those sorts of things. So I appreciate that, and that's why I asked for a careful look at. We can't just say operating expenses are growing, and a highly efficient organization could control those. I think there are multiple factors in play. We are at capacity. I think we're looking at maybe some of the wrong numbers. When I hear we have 3 ICU beds left in a day, I am concerned about the care for Vermonters. So is it utilization driving expenses? Is it workforce, never mind travelers, but the need for more staffing, nurses, doctors, PAs, environmental service people? When I walk in these organizations and look at shelved cafeterias and places where patients can't get a healthy meal, I am concerned. And that's where we're headed. I agree with the sustainability and affordability conversation, but the choice is access, which is challenged, or creating more problems with those access issues. It's simple to me, and it's very complex with all of the details. Thank you.
Great, thank you. Mr. Stanislaus?
Thank you. I'm Mark Stanislaus from the University of Vermont Health Network, and I just would like to echo some of the comments that Mike Del Trecco said and add on to a couple of them. First thing I would say is this is a lot to digest. So I just appreciate all the hard work, but this is a lot to digest. So I just have some high level comments for consideration. This is nowhere meant to be encompassing of all of the comments, to be very clear. But the first thing I would say is there has been a lot of reach outs, okay? And that is very, very much appreciated of the conversations from all levels of leadership, from the staff at the Green Mountain Care Board, to the members of the Green Mountain Care Board, to the chair of the Green Mountain Care Board. But there is a struggle to see how all of that reach out and input carries over to this guidance. So I just have to echo what Mike said, because while not being in all of those conversations, but being aware of them, that doesn't mean that we don't have a common purpose together. But by saying that, I'm just reacting to, there was a lot of comments at the beginning to say, all of these reach outs happen. And there's a struggle to see where that feedback flows through this guidance. So I just wanted to share that. So I'm just going to go through a very couple high level things. I'm just looking at slide 7 and slide 8, and there's a lot of reference here to the all payer model. And, you know, I know we could talk about percentages over and over, but we have to move to a per population based tracking. That's been said many years now for many times. That's what the all payer model is built on. We're mixing and matching stats here that are apples and oranges. So I just want to say that jumping on some of the expense trends too, I also think that needs to be population adjusted, because if you just look at slide 15, there are some of those New England states that have out migration. There are some that have in migration, okay? And from an expense perspective, I think it's very important when we look at expense trends that are built into the hospital's financials, that there are some expenses in there that should be carved out when we take a look at expense trends, okay? Well, there's retail pharmacy expenses that does not tie to net patient revenue. That is something completely different. There is provider tax trends. That's a cost share to a governmental program. There are other cost share expenses that relate to governmental programs. And if you were to take those out as an example, I bet you from 2021 to 2023, the actual expense growth would be at least $100 million less. So I think the expense items that are being shown as it relates to true hospital expenses and care to those patients that are seeking at the hospitals, I don't think they're fairly presented in some of these slides. So that's something I would tease out there. And as we think about commercial growth rate and how we think about that and how we manage it, I would really caution the process that it would be best to have a conversation to say, why are those expenses in there? And when I take a look at slide 25, there's just some components of that in doing this business now for 30 years that it just doesn't relate to how hospitals get paid. And I'll just point out a couple things that when you look at rate growth, it needs to be actual to actual. Well, there's no budget in there, okay? Saying that you need to look at hospitals' productivity by department, when it comes, hospitals don't get paid by department. They get paid by encounter. So, you know, there's just aspects of this that even if we wanted to do it, I don't know how we practically could do it based upon how we're paid. And then if you just go to slide 27 and just kind of thinking out loud, I think it should be, how do we create a sustainable healthcare system to meet Vermonters' needs? There was very little in this on how do we balance some of these numbers against the care needs for Vermonters. That's ultimately, you know, what our shared purpose is. So I think that is something, because what happens when those against this guidance? How do we come together in a conversation? And there's no perfect answer here on either side, but there's nothing in this guidance about how do we work together to meet the increasing health needs and access needs of Vermonters. And there's nothing in here about what does it mean to be a financially sustainable hospital, and how does that balance against? So, and I have to say that what Ham said, aging has a big impact on the resources that it takes for hospitals to provide care to aging patients. They seek care more often. It's more intensive care. It's usually in a higher care setting. So there's no easy answer to all of this. Okay, I also want to say that. But I think for us to work together to find a solution, that we do need to put this down on paper on how we come together to tackle it together. There needs to be a little bit more of a strategic plan on how we do it together, to just reference one benchmark. And I would also like to remind everyone, there's some specifics in here about the commercial payers, but hospitals have a lot more patients. There's a lot more Vermonters that don't have commercial insurance than do. So significantly more. So will we welcome the conversation on how we can balance all of this together? How can we make, I think the affordability that you were trying to refer to is like, how can we control the growth of healthcare compared to other benchmarks? But very much welcome the conversation. So I just wanted to point out some of those things, and I'm sure that we're going to be following up with some written comment. And I would just like echo what Mike said. There's so much here that anything that can be done to expand this deadline to fairly comment would be extremely grateful. And I also think the Vermonters seeking care would benefit from it also. Thank you very much for this opportunity.
Thank you. And any suggestions you have would be welcomed. So please definitely send them in. I don't know the rules around extending the deadlines. I think it's in statute. I'm happy to look at that. Might make it tougher to get your budgets together because I know you're working on them now if this isn't done, but we can certainly, I would be interested in whatever suggestions you have to recognize those points that you made. Is there any other? Oh, go ahead, Mr. Stanislaus.
Actually, thank you, Chair Foster. Again, so like, I would just like to say something. When hospitals put their budgets together, the analysis done on this guidance is done afterwards. So us building our budgets, or say you changing it, the way the hospital budgets are built is we anticipate what the volume needs are going to be, and then we build our budgets on top of that based upon what the current run rates are. So said another way, we take a look at the patients we are serving today, the patients that are coming to us because they need care, and we take the expense relationship to that today and we build that moving forward. And there are some volume trends that are built in there. So I don't think if we extended this deadline, and there's a lot of CFOs on this call here, but I don't think it would impact the hospital or how the hospitals build their budgets, because we really focus on what the care demands are on the hospital, and then we build the budgets up from. So thank you very much for the additional opportunity. But so I thought I would just kind of throw that out there because I don't think that would impact hospitals at all if that deadline was extended.
Great. Okay. And I assume you're with a hospital?
Yes, I'm with the University of Vermont Health Network.
Okay, great. Thank you. Any other public comment?
Chair Foster, could I just ask for a quick clarification from Mr. Stanislaus? He suggested modeling, removing provider tax, outpatient pharmaceutical growth, and there was one more area, and I was writing it down and I missed that.
There's another cost share that were related to a governmental program well, that we can follow up on. That's that I think everyone in the state, actually it is part of our net patient revenue. It is the GME IGT payments. So I think if you did those expense trends and when you took those out, you would see a really, really different trend line. Thank you for asking too, by the way, Dr. Merman.
I'm gonna follow up on that too, if you don't mind, just to make sure I get it. I mean, I understand that. Would we need to make adjustments to other states too for particular things, or are these only particular to Vermont? I know some of them are, or at least one is. Or do the other ones have other things that we'd need to change to make them apples to apples, or no?
Well, I would say I'm not sure either way. I would say that there are a couple of those categories that like first of all, I don't know what other expense or what other states with their provider taxes, but at the end of the day, there's a lot of comparison in here. I'm saying this is the expense trend compared to the revenue trend. Okay, so ultimately, I'm just saying there are expenses in there that don't tie to the revenue trends. Okay, and so like all of the retail pharmacy expense that is built through like in other states we know, and in this state it also goes through pharmacy. So I don't know what their structure is, but I'm telling you that those percentages don't relate to the NPR trend. So if you're going to connect those two, and also it also depends on if some of those expenses were already in their base before to if it's new. So, but I'm just saying it would be interesting to take a look at what the total growth would be. And since the University of Vermont Medical Center drives that trend growth for the state, I just think you'd see a different trend line in a lot of these. That doesn't mean it may or may not be where you think it should be either. So.
Okay, that's helpful. Thanks for clarifying. I think that's all we have for comment. I appreciate everyone attending and listening and sharing their views. Is there any old business or new business for the board? And is there a motion to adjourn?
So moved.
Second.
All in favor, say aye.
Aye.
Aye. And we are adjourned. Everyone have a nice day and I hope you get to enjoy the snow. Thank you.